Good morning, everyone. The topic of my paper is clinical profile, complications, treatment, and visual prognosis in sarcoid uveitis. Sarcoidosis is a systemic inflammatory disorder of unknown etiology characterized by non-caseating granulomas that primarily affect the lungs and lymphatics. Ocular involvement is seen in around 60% of sarcoidosis cases, of which uveitis is the most common feature, seen in 30% cases. Diagnosis of ocular sarcoidosis is based on the revised AIOC criteria established in 2019. The aim of our study was to determine the clinical profile, complications, treatment, and visual prognosis of sarcoid uveitis in the South Indian population using the revised AIOC criteria. This was a retrospective observational study for a period of 18 months, and we enrolled 94 eyes of 51 patients. We documented the age, gender, symptoms, and a detailed history regarding the onset and progression of the disease. The best corrected visual acuity was measured using a Snellen's 3-meter chart, and we also examined the anterior segment and fundus and noted the intraocular pressure. These were the investigations we did for our patients, and the treatment modalities mainly included corticosteroids, immunosuppressive drugs, cycloplegic agents, and IOP lowering drugs. According to the AIOC criteria, we classified the patients into confirmed, presumed, and probable sarcoidosis, and anatomically into anterior, intermediate, posterior, and pan-uveitis. The BCVA was measured at presentation 1 month and 6 months, and this value was converted to logMAR for future comparison. In results, we found that 54% of the patients in our study had probable sarcoidosis, 44% had presumed, and 2% had confirmed sarcoidosis. There was a significant female preponderance, with 90% of the cases being female. The mean age at presentation was 48.66 years, and the most common age group affected was 51 to 60 years. The most common symptom observed was defective vision, followed by redness, floaters, watering. Most common anatomical presentation was anterior uveitis, followed by pan-uveitis, intermediate, and posterior uveitis. The most common anterior segment findings were AC cells, keratic precipitates, and AC flare. A few rare findings included band-shaped keratopathy and conjunctival nodules. The most common posterior segment findings were vitritis and vitreous exudates, and a few patients demonstrated periphlebitis, optic disc involvement in the form of optic disc granulomas. The most common complication observed was chorioretinal scarring, followed closely by secondary glaucoma. Other complications included cataract, cystoid macular edema, vitreous hemorrhage. 88% of the patients in our study demonstrated a non-reactive MANTO. 80% had elevated serum ACE, 32% demonstrated lymphopenia, 36% demonstrated features of sarcoidosis on X-ray chest, and 52% demonstrated features of sarcoidosis on CT thorax. The most common treatment modality used was oral steroids, which was used in 96% of the patients. Only 19% of patients in our study needed immunosuppressive agents. There was an improvement in the mean BCVA at 1 month as compared to that at presentation, and this improvement was maintained at 6 months, which was found to be statistically significant. In discussion, significant female preponderance was observed. However, no bimodal peak as reported by other studies was seen. Other studies have demonstrated pan-uveitis to be the most common presentation. However, in our study, we found anterior uveitis to be most common. Considering the expensive and invasive nature of performing biopsies, majority of the patients in our study were diagnosed using radiological and blood investigations as per the revised AIOC criteria. A higher rate of negative MANTO and elevated serum ACE was observed. Positive findings suggestive of sarcoidosis on radiological investigation was lower than that of 2 studies on Caucasian and Turkish populations, and was comparable to that of another study in the Indian population. Requirement of oral steroids was higher, and that of immunosuppressive agents was lower. In our study, at the end of 6 months, 21 eyes showed improvement in BCVA, and 12.76% eyes demonstrated a decrease in BCVA. This is a table demonstrating a comparison between studies on sarcoid uveitis in different population groups. The strength of the study includes systemic categorization of the patients into by the AIOC criteria and early diagnosis. The drawbacks include a small sample size, shorter duration of follow-up, and lack of biopsy-confirmed cases. Also, being a tertiary care hospital treating only ophthalmic disorders, evaluation of systemic features of sarcoidosis and progression from ocular to systemic disease could not be studied. In conclusion, I would like to say that uveitis attributed to sarcoidosis appears to be underdiagnosed in India due to the fact that India is a tuberculosis endemic country, and both these diseases present with similar ocular features. Given the expensive nature of biopsies, the application of revised AIOC criteria can be used for early diagnosis and treatment of patients with ocular sarcoidosis, which will in turn minimize the incidence of complications and ocular morbidity and aid in prompt referral for systemic workup, since many patients present initially only with ocular features. Thank you.
How will you rule out tuberculosis before starting any? If like 80% you are telling tuberculosis, if 80% is confirmed with tuberculosis, otherwise you are thinking sarcoidosis.
No, sir.
Ah.
According to the revised IOS criteria, there's criteria. If there's a negative tuberculin test, it is points more towards sarcoidosis. That is a diagnostic criteria for sarcoid. So based on the criteria, the patients which fulfilled those criteria, we classified the patients into confirmed, presumed, and probable. So as long as there was no definite evidence of tuberculosis, we considered the patients to not have tuberculosis, and if they fitted the criteria, we classified them into sarcoidosis.
That is a very strange thing about sarcoidosis, that when you are treating sarcoidosis, unless you have a biopsy report with you, most of the time these post-viral inflammations also mimic sarcoidosis. So we'll take your findings with a pinch of salt here, because you did not require continuous immunosuppression in most of your patients. So
Yes.
that goes slightly against the diagnosis of
Yes, sir.
sarcoidosis.
That is a limitation because our study period was short.
Short.
Yes, sir.
No, but anyway, good work.
Thank you.